Well, good morning, everyone. Welcome to Friday Chalk Talk. My name is Ruth Payne, and I'm a chaplain with Advocate Aurora, and I serve at Aurora St. Luke's Medical Center here in Milwaukee. I'm grateful for this opportunity to moderate today's discussion and to introduce to you our presenter. Miss Brittany Chambers comes to us from the East Coast. She resides in New Rochelle, New York, but is currently in Maryland. And Brittany works at the Center to Advance Palliative Care. Ms. Chambers leads CAPC's health equity efforts, currently managing the initiative focused on equitable access to quality palliative care for Black patients. She also serves as a reviewer of CAPC's online clinical curriculum to ensure that the clinical training content is culturally responsive and oversees the coordination of virtual learning events for CAPC members. Ms. Chambers is a master certified health education specialist and worked as a health educator at Kaiser Permanente Capitol Hill Medical Center in Washington, D.C. Brittany also has experience working on NIH-funded disparities research studies, and she has co-authored academic peer-reviewed articles. Ms. Chambers completed a health disparities research fellowship prior to joining CAPC. In 2020, Brittany was on the planning committee and moderated the National Academies of Sciences, Engineering, and Medicine Roundtable on Quality Care for People with Serious Illness webinar entitled Serious Illness Care, Structural Racism and Health Disparities in the Era of COVID-19. Ms. Chambers is a member of the Delta Omega Honorary Society, was named one of Drexel Magazine's 40 Under 40, and featured as one of the People on the Move by the Journal of Palliative Medicine and Health Equity. Ms. Chambers received her Bachelor of Science in Community Health from the University of Maryland, College Park, and her Master of Public Health from Drexel University School of Public Health. Brittany enjoys reading African American fiction, playing tennis, and traveling internationally. Brittany will lead us through her presentation on implicit bias and the impact on healthcare disparities. At the end, there will be time for discussion. If you have any questions, please put them in the chat and they'll be addressed after the presentation. We'll also include 4 questions in the chat that we'll use to encourage discussion at the end. Brittany, thank you so much for being with us here this morning. The floor is yours.
Thank you so much for that warm introduction, Ruth. And the goals for today are to talk about, how implicit bias specifically contributes to healthcare disparities. We're going to discuss some strategies to help to mitigate implicit bias. And then specifically, because this is a palliative care group, we're going to talk about the ways that we can take action to begin to address disparities, as I mentioned. Next slide, please. Thank you. So I always like to start the talk just to clarify some definitions. So when I'm using different terminology, we can kind of all be on the same page and be using the same type of language. So here I have listed structural racism, which is defined as a system in which public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways to perpetuate racial group inequity. Healthcare disparities are the differences in access to or availability of medical facilities and services, and the variation in rates of disease occurrence between populations. And then when I'm talking about implicit bias, I will be specifically talking about the different attitudes that we have towards people, or the way that we associate stereotypes without our conscious knowledge, so that they're operating at a more unconscious level. And I do just want to note, and I'll say this throughout, that we all have biases. If you have a brain, you have a bias. That's kind of how I make the analogy between the two. So you should never think that, oh, this person may have it and this person may not. We all have them. This next slide. So I want to just quickly talk about the fact that I think we're all clear that COVID especially has made healthcare disparities and inequities more visible. they have always existed, but I think we now, because of COVID, because of the rates of death and morbidity and mortality, we know that there are certain communities who were impacted by it in very different ways. We know that Black patients, Hispanic patients, they tend to have COVID, be diagnosed with COVID and end up dying more than their white counterparts. And then I want to also just mention that these disparities also manifest for those who are diagnosed with a serious illness, especially towards the end of their lives. So I just want to quickly share 2 examples of racial health disparities for those with serious illness. So in the US, we know that, cancer impacts everyone across the board. However, there's data that show that Black patients have higher death rates due to cancer than white patients. And one even more specific example is the rates of breast cancer. So Black women are more likely than white women to die of breast cancer, and it's often because of a late diagnosis. Another example I could share is heart disease. We know that Black and Brown communities often have more barriers to accessing heart disease care, unfortunately receive lower quality treatment, and then that results in worse outcomes. And then to now tie in the language and the definitions that I talked about before, these disparities that I'm discussing, they're all tied back to structural racism and the fact that these communities, they experience different social determinants of health, whether that's lack of income, lack of education, opportunities, all of those intersect to then lead to the later outcomes of these health inequities that we see. Next slide, please. Again, I want to tie it back to the serious illness care lexicon, because I know that's what we all are here and work in. And so again, just more studies that talk about the fact that unfortunately, Black patients are not believed when they're reporting symptoms of pain and distress. And it's even more alarming, we know, for our community, because if you have a serious illness, we know that the disease trajectory, changes very throughout, and that can be very distressing to a patient, that they're telling their provider that, I'm feeling these ways, and they're not being believed. And then we also know access to pain medication is an issue. I know specifically there was a study in New York City that found that access to opioid medication in pharmacies in Black and Brown neighborhoods was way lower than in white neighborhoods. Those communities were less likely to even have opioids in stock, which again speaks to the unequal access and to high quality care that I know as palliative care clinicians, all believe is central and should be equitable across the board. And then the last thing I'll note about the symptom management is that we know from patient experience studies is that Black patients will report that they don't always feel that the care that they've asked for, like the preferences they have, are always end up being what they receive. So there's some kind of disparity there between what they've asked for, or what they've perceived that they've asked for, and what they end up receiving. And I think that again goes to trust. If patients don't feel that they can, that their care is aligned with what they want, that again erodes and starts to increase the mistrust that we know that exists for these Black and Brown communities. Next slide, please. So communication, again, another hallmark feature of good palliative care, right? We know that, palliative care providers have been trained in this core skill to ask patients what's important to them. What are the values and things that they want throughout their disease trajectory. And again, unfortunately, the literature shows that, especially in cancer care, that Black patients feel as though their communication with their providers is not always the best. They feel that their provider is more verbally dominant, that they're not able to be, provider, like in tandem with the provider to make decisions. They feel as though sometimes information is just being thrown at them and that they're not a part of the decision making. And we know that if a patient doesn't feel as though they're a part of the conversation, that leads to decreased adherence to medication regimens and all of those factors. And so I think all of these kind of things that I'm talking about leads to the issue of more training for clinicians across the board who care for these seriously ill patients. So, training that talks about how to be good, good, good as far as like listening, using active listening skills, knowing when you've said enough, and like give the patient a chance to now first of all talk back, like make sure they understood what was said to them. What did they really understand about their diagnosis or about what's about to happen next? Really, that rapport and relationship building is very, very key. Next slide, please. So now I'm going to get into more of like mitigation strategies. So, okay, we know implicit bias exists for everyone, but in the healthcare setting and for providers specifically, what can we start to do to start to try to reduce some of those biases? And then, hopefully, along with other things, because this is a multi-pronged problem, of course, implicit bias won't fix everything, but what's in our sphere of influence and what can we start to do to start to make a difference? So this is like a 4-pronged screen that talks basically about the themes that I want to pull out and things that I believe can start to address more of the self-awareness within all of us. But basically the fact, again, bias is universal. No one is immune from being unbiased. And I think that's why I've asked, hopefully you all had a chance to do the implicit association test. It's not perfect, but it is a way to measure kind of attitudes and automatic responses to visualizations to see what may be something under the surface that you hadn't noticed before taking the test. It's all about trying to get out of those blind spots and start to understand, like, okay, that's something that I could work on or should work on. Then designing practices and processes for mitigation in advance. One example I can think of that I've heard from providers is doing a pre-brief. I know everyone knows about a debrief, but a pre-brief is before you're being consulted, can you take a minute to be more mindful and pause before going into the room with the patient to like acknowledge, okay, I know we work in an environment where you have to be fast-paced, but there is something to be said about taking a moment to slow down a bit before you walk into the room and you unconsciously make assumptions about the patient, and the importance of individuation. When you go in there, you may know something about this community, but the person in front of you has a different story and a different, has experiences up until the point that they walked into the room. And so just acknowledging and hearing what they're going through and how you can establish some rapport with them, because honestly, that will make it go a long way. And then they will start to trust you. Again, focusing on the cognitive strategies, it's all about slowing down and trying to reinforce the importance of who's in front of you and what they're telling you and what you're perceiving, and making sure, like clarifying, like, this is what I heard you say. Is that a fair acknowledgement of what you said? And then the fourth one, again, is just creating a culture. So also like the fact of, yes, it's individual self-awareness, but then how do you make that a part of your team culture? One thing you could do in addition to the pre-brief is the debrief. So talking about different cases that you've had, which I think you probably all do, but talking about how culture or any of those type of things have come up in the case study, and be open to another team member saying, like, well, my observation of what happened and what you may have done, and not being defensive. I think that's another important part of like being in this environment, is like lowering your defenses and knowing if someone is bringing something to your attention, it's for the good of the team and the good of better patient care. It's not an attack on the person. Thank you. The next slide, please. So then again, these team actions, I'm just reinforcing the themes about normalizing and making it okay to uncover and talk about bias, recognizing the contributions of others, even if they're not in the room, is really important. And then modeling, if you lead a team, how can you hold yourself accountable? Like, you don't have to be perfect. If there's a misstep or you did do something or say something wrong in a conversation with a patient, share that with your team. It then makes it okay that, people will then start to surface, like, I don't have to be perfect, and that I can like bring this with my team. This is a nice, safe space to talk about what went wrong and the fact that we don't want that to perpetuate and continue to flourish amongst our group. Talk about the hard things. I think we've all, especially I know at CAPC, we've genuinely had to surface conversations that maybe wouldn't have happened in 2019 because of everything that has happened in our healthcare system and in our world at large. So let's start to make these difficult conversation like the norm and not shy away from them. I think where the difficult conversation lie is where real learning and transformation can happen. And then again, which I think most of palliative care, at least because most of the palliative care clinicians that I've encountered, like are such great people. That's why you get into this specialty, but just continuing to show that genuine concern, both for patients and for each other, and knowing that we're all doing the best that we can. And then the next slide, again, is the summary just of, trust. Again, I cannot reiterate that enough. I think you probably all have read in the literature about how important trust truly is in relationship building, especially with Black patients, historically and ongoing, the mistreatment. So it's all about like trying to I would say, establish new trust, but also acknowledging what has happened in the past, and try to move forward so that you can showcase. I think we see with the vaccine hesitancy that some groups are not being vaccinated at the same rate, and that has again to do with the mistrust. So just knowing that, like, when you go into conversations, listen more, and then interject as appropriate. Again, as I said, about just acknowledging your own biases, because that just leads to better care. Communication around serious illness topics do require special sensitivity because, again, as I talked about, just our legacy in this country, and what continues to perpetuate, unfortunately. And again, just my biggest thing is about creating the culture, about pausing, and instead of, I've heard other people in the space, instead of saying calling people out, we're calling you in, because we're trying to say that we're not trying to make you feel bad about anything. It's literally about all of us improving. So calling in is more about more of a reflection of, we are trying to do better. And so we're saying things and bringing things to your attention so that, better patient experience and just better team harmony and team cohesion as well. And then, one quote that I love to always say from Dr. Sharika Newman out of Emory, she always says, what you permit, you promote. So I think we all have to be allies and know, like, if you see something, you can't just be a bystander. I think maybe you don't want to call in the person in the moment, but at some point, after an experience, you should be saying something to them. Otherwise, you're part of the problem because you just let it continue. And you're basically saying you give permission for someone to behave in a certain way. Okay, so then now, after all that speaking, I'm actually more excited to hear from the group. I hope you guys had a chance to do the implicit association test. There are a couple of disclaimers on this screen just for everyone to know that if you have any specific questions about the IAT in particular, I can share the email of the project coordinator who runs the actual test. The test is just one example of how you can start to try to uncover biases, but of course, this is not end all be all. And that it really is just an association to see how people quickly respond to different visualizations and what that kind of means in the brain, like how it works in the brain. People have done studies and they found that the IAT does predict discrimination in hiring, education, healthcare, law enforcement in those settings, but that they do reiterate that doing it one time doesn't predict that that's like how you'll be forever. Don't think that like, oh, I took the test, oh no, like this isn't good. Like, we all are malleable and we can change and we can shift, and all of that is possible. So I just don't want anyone to feel bad about any results. Like, and I'm happy to share what I received as well. Like, it's all about learning, growing, and transforming. So I'm looking forward to a good conversation with the group.
And I'll start. I'll try not to take too much time. But I took the test last Friday, And I was extremely disappointed with my results. And I immediately thought the test is biased. And I emailed Brittany and said, can we talk about this? And then over the weekend, I spent more time and really got in touch. I'm a perfectionist. And so got more in touch with what was going on inside of me, and also what position I was about to put Brittany in by getting her to help me feel better about having a bias. And so that was really instructive, and it's been instructive since in terms of just owning, continuing to own, and I have, well, and we all do, like multiple biases. And so now being able to say them out loud, at least to myself and to a few trusted people. But I really appreciated the test, as uncomfortable as it was.
And Ruth, what I really appreciated was that you did take that after you emailed me, but then you did email me later on and said, I just needed to take a moment, because I think when you first see the results, like I think as humans, our default is to be defensive and want to defend what the results are. But maybe it's just like, sitting with it for a moment, like what you did, instead of like trying to like, oh no, like I'm a perfectionist, this doesn't align with how I view myself. You took the time to say like, actually, let me sit with this a bit. And I think that was actually a brilliant case study in how we should like perceive of these results. Has anyone else taken it? I'm wondering if anyone else was surprised by the results or confirmed what they had already felt or anything like that.
Yeah, when I took it, even reading the questions felt cringeworthy. Like I wrote down one of them: certain groups should stay in their place. Like it just bothered me to even read some of the questions. And despite that, I still showed that I had a significant amount of bias. And the same way as Ruth, I immediately thought there was something biased and wrong with the test. And I think it took me a while to sort of settle down and realize, I think this is more about just, it's recognizing it exists, it's real, it's because I'm a human being. It's more not so about eliminating bias, because that's probably not even realistic. It's just recognizing where I'm at.
Absolutely. Yep. It's just understanding like those are unconscious, and the automatic side of it is just like, that's why they tell you to take the test quick. Like they just want you to like just choose a response, because if you did take a minute and pause, I think your answers could have been different, right? Like if you really sat and thought like, okay, before I click this button, like I get a chance to reflect on it. Yeah, it's interesting. I think it's an interesting test. I usually do it once a year. I know I told you all to do the race IAT, but there are other variations. They have gender, they have religion, like there are like maybe 10 or 11 other types of tests. So, I think it's interesting to try those as well.
I was curious, even with it asking you to go quickly, like even, so I took it twice, but that even if you did take time, that it was measuring where you took more time, right? So it wasn't about getting the answer right or wrong, but the amount of time it took to respond. So I was just guessing that was also part of how they determined results.
Right. Yeah, because I'm almost assuming that they're like, okay, you took longer on this one because you had more time to think about it, because you're trying to pick a response that you think it wants, like, yeah.
It wasn't natural. It wasn't natural to say black good.
Right.
It was natural to say white good. That was easy. And so I want to get it right. So it's just going to take me a little bit longer.
Brittany, I've got one more observation and one question for you. So one is that I took a couple of different tests, and I noticed that while I had bias in some of the other areas, it was the racial one that bothered me the most, as opposed to the other ones. And maybe that is because of the moment and the time that we're living in, and that is more at the forefront. But the second one is, as you guys are collecting data on all of this, what do you think? Where's this project headed? Is there like a phase 2 or something you guys have planned for the future of what to do with all of this?
Oh, so I should make the distinction that CAPC is not associated with this particular project or implicit bias. It's just one thing that in our like set of tools and resources that we recommend people check out. So that's a great question, and one I think we should email the they have a whole project coordination site at Harvard that I think I would love to know the answer to that as well. Because I think in one of the slides I showed that they had like a breakdown of the types of like the rates of people's like biases between 2005 and 2015, I want to say. And so I would love to say, like you're saying, like maybe look at the what the data looks like for 2021 after we've had like such a hard and interesting moment from 2020. Like I wonder how that would look. So I don't have the answer to that, but I'm certainly planning to email the team to ask back, because I'm sure people are thinking that as well. But on the CAPC front, so when Ruth read my bio, we are working on an 18-month grant that looks at how we're looking at specifically what goes wrong for Black patients, which we have some articles that we've all shared, but we're doing a more formal environmental scan with the formal literature review so that we can have a landscape of the land. Then we're doing an informational interview series to learn more about what interventions work. You know, like, okay, we know what the problem is, but are there interventions where a palliative care site or any type of intervention where the outcomes for Black patients were better because of a specific intervention? What was that intervention? And we at CAPC, what we do best is to try to like help people to replicate that intervention, to scale it, to disseminate it to our audiences. And so that kind of information will be available in 2022. So we're at the forefront of undergoing that project. It's not just on implicit bias, it's more about interventions that will improve the care experiences of Black patients living with a serious illness.
One other thing I'd like to mention that I've started doing since I took the test to mitigate bias is to all of my different biases that so far I'm aware of, I will say out loud the group, whatever the group is, and I'll say good, right? Because we were hitting good and bad as the two answers in the test. So I just will say the group and I'll say good, Black, good.
Like trying to retrain your brain a bit. I'd love to hear from the group. Like I during the pre-talk, I talk about the importance of like the culture of your team and your organization. Has anyone, I know at CAPC on our education team, we've tried to start to like normalize and talk about, you know, someone mentioned in one of our CAPC courses that maybe we should be using non-binary terms and saying they and being more inclusive. And that's really helpful feedback. I'm just wondering if anyone can share anything they've done on their team to try to be more transparent or to normalize calling in amongst each other. I'd love to hear from you all.
Yeah, I find it, and we're used to having difficult conversations, but difficult conversations in which we've practiced and we have vocabulary and we've read lots of articles and gone to conferences to learn, oh, that's a different way, or observed other people doing it. So you're like, oh, I like the way you said that. But, you know, so for serious illness conversations, that we have a whole stew of knowledge to gather from. But I find that having these conversations, while difficult, I don't necessarily have a vocabulary and lots of exposure and experiences that say, I really like how someone addressed that instance of overt racism or a microaggression, or maybe it was none of those things, and maybe it was a misunderstanding, a miscommunication, and that's how they addressed it. So I've tried to both call in and call out when I see it, but I haven't always felt real great about. I haven't felt the same confidence I have in other difficult conversations. So.
Right.
But I found that I still need to practice. I still need to work through it and recognize that even if the conversation doesn't go well, to to have that be actually part of the conversation with other people, to say, like, I'm not really sure how to say this, but this is something I think we should talk about.
Yeah, actually, I love that. I think starting the conversation with saying, yeah, this might not go perfectly and I may stumble and use wrong words, but I think showing that transparency, and we're like, it's okay to be human. I think there is this like inclination to be perfect, use the perfect terminology, but at the end of the day, I think engaging in the hard conversation, if it doesn't go quote unquote well, is better than avoiding it because you're scared of saying the wrong thing. Personally, thank you for sharing that, Dr. Sinclair. I appreciate that.
This is Kate McKillop in Omaha. So our team has evolved over the last 3 years from being a very private practice model to an increasingly academic service. And I can say that the presence of learners on the team has really lit curiosity and dialogue among our team. Our team is not representative of the demographics that we serve. And we've had some really, the fact that learners have been present on the team has stimulated reflective practice and engagement with trying to be more aware of our own implicit bias on the team. And so I would say, and part of that's coming from a place of like, we want to protect the learners on our team.
Carrie, you were going to say something as well?
Oh, I was just going to comment, I guess, that like one of the things, as others have said, like I want to learn and improve myself. One of the things that I've come to realize and come to really respect is how you have to kind of, as you're approaching your own learning and improvement, you have to respect those that you're learning from, I guess. I'm trying to think of a better way to say it. There's a time to learn, there's a time to ask questions, and then there's a time to not do those things, depending on the context and the situation. Is that making sense? Like sometimes it can be easy to be like, feel like you want to ask all these questions and learn all these things, but your questions may themselves be intrusive or offensive, and there's a balance. You can be like, well, I'm just trying to learn, it's great, I want to learn all the stuff, but you have to really balance that with what you're doing. I hope that's making sense. It seems like, Ruth, you're getting it.
Yeah, it was the example last Friday of me like reaching out to Brittany and then saying,
Yeah.
Yeah.
That's a good point. It's directly that.
Brittany, thank you so much. Is there any last thing that you want to say, just being conscious of the time? I mean, what a gift it is to have you with us and to have this presentation. Anything else that you want to add?
No, I just want to thank you for inviting me. I've enjoyed the time. I think this series is really great. And I see in the chat that Kate might do an article, so I hope I can come and listen in on that, because it sounds like it's going to be a great conversation as well. So thank you. Thanks for having me.
You're welcome. You're welcome. Thank you, everyone, for participating.
All right.
Take care, everyone. Stay safe.
Thanks, Brittany.
Thanks, Brittany.
Thanks, everybody.